Okay, this is Michael from Blue Sky Bio, and I'd like to welcome everybody to the first webinar presentation of the 2018 Blue Sky Bio webinar series. We already have 10 to 12 webinar presentations scheduled, and you can see the upcoming schedule at blueskyplan.com/webinars 2018. The webinars are recorded and uploaded to YouTube. If people can't attend live, then you can watch them via YouTube. Just search for Blue Sky Bio. You'll find our channel and you'll get notified every time a new webinar presentation is uploaded. If you have questions during the webinar presentation, please type them into the chat box to the right of the video screen, and we'll try to address them during the presentation. I've also put in that same chat box a link to the webinar attendance form. Please make sure to fill out and enter your details into the webinar attendance form so that we could send you the CE credit. We have a lot of new and exciting updates coming to Blue Sky Plan in the next couple of weeks and months. One of the ways to stay up to date is joining our Facebook group, the Blue Sky Bio user group. We post all updates there. You'll get notifications, and you can take advantage of the new features and functionalities that we're going to be delivering. Tonight, we have the pleasure of hearing from Dr. Daniel Domingue on the topic of avoiding complications in advanced full arch surgery. Daniel?
Michael, thank you for having me, and thanks Blue Sky Bio for having me. So yeah, Michael said that today's lecture is avoiding complications in advanced full arch surgery. I'll just go ahead and start into the lecture. This is a Blue Sky Bio webinar. I'm not getting paid by anyone, and I'm not getting paid by Blue Sky Bio or anything that I'm presenting in this lecture. And all of the images that I'm showing today are not photoshopped. I'm Daniel Domingue. I'm a dentist in Lafayette, Louisiana, my hometown. I did a postgraduate residency at Brookdale Hospital, 1-year general practice residency, and 2-year implantology fellowship. And I eventually went on to get my fellowship from the AID and the diplomat from the ABOI.
Daniel, can you raise the volume from your side a little bit?
Can you raise the volume of my microphone?
Yeah, that's better.
Okay. So I'm going to demonstrate how to avoid complications and present 2 main case presentations. The first case presentation is our patient that I treated in 2010, 58-year-old female. She lost her teeth 30 years ago. She is wearing a lower denture that she hates. She doesn't wear it. She can't chew. She's gained a lot of weight due to inability to chew, and thus she chews softer foods, and she wants implants. She's been wanting implants for many years, has seen a lot of dentists for different consultation visits, and hasn't been satisfied. So eventually I saw her in 2010. Initially, whenever you're looking at these images, I want you to think about what you initially see in the presentation of the soft tissue. My initial thoughts are we have a lack of keratinized tissue, but a nice vestibule. If you look at the Panorex view, you can see that she has plenty of bone in the mandibular anterior, and she has mandibular atrophy in the posterior mandible. So next, we want to get a CT image, and cross-sectional CT, you can see there's an obvious class 3 issue that is going to present a complication during the restorative process. And how do we fix this? And we'll tie all this in together in a second. So initially, for surgical complications, just looking at the Panorex, the CT image, and the picture of the soft tissue, we obviously have a soft tissue deficiency, posterior ridge deficiency, and skeletal class 3. Looking at some slices of the CT images, you can see this might be difficult for everyone to see, but to get down to this cross section here, this is 4.2 millimeters, and from the tip of the mandibular anterior ridge all the way down to this portion is 11.7, so almost 12 millimeters till we actually get into some good bone. And here's another slice. on the other opposite side. So you can tell that for the first 12 millimeters, it takes till you get down to good bone at 4.5 millimeters. And so looking at both of these images, do we, the surgical initial visit, do we graft this area or do we remove this area is usually what I'm thinking. So what I did was I treat and plan my implants, sites and sizes our patient wants fixed. So approximately 8 millimeters of bone from the tip of the crest down to the head of the implant is where I can get my implant to sit in, but not having 1.5 millimeters of bone surrounding the tip of my implant. So again, I'm going to have to place that another 4 millimeters down. So I worked this up in vivo dental and Amatage software, and looking at all these images. This is how deep I need to go with my implants to place these in good vital bone. So the day of the surgery, the biggest thing that I have on my mind is the soft tissue, the lack of soft tissue that is. Also keeping in mind the ability to remove the bone as opposed to grafting and full thickness flapper flexion as seen in here. So what I do is I take a 15C blade and I make an incision splitting the keratinized tissue at the crest. I sound to bone with the 15 blade and I move it across the arch all the way to the opposite side, retromolar pad to retromolar pad. And then I do a full thickness dissection. At this point in this image, I went back and forth to my CT scan. It's very difficult at this point because you kind of lose all your landmarks. So I use landmarks of my middle nerves on both sides, and basically the mandibular anterior, the spine of the mandible. I'll just measure across here and measure about 5 millimeters across where my implant's going to go and down 12 millimeters. And what I'll do is I'll take a burr and I'll bore a surgical burr into the bone, into the mandible. I'll do the same thing at each implant site. I'll go down, measure, go back to my CT scan, come back and forth and back and forth. So going from the spine, I'll move across, go 12 millimeters, poke a hole back from the spine, and going back and forth with my image. Here's the middle nerve, and I'll transverse back and forth. It's difficult to do, but it's, if you're going back and forth from the CT scan, and I keep it behind the patient, I'm able to plot out how much bone we need to remove. So what I did was I removed the bone, flattened out the ridge, and then you can start seeing I'm getting some good vital bleeding in this bone, in this area. I'm very happy at this point. This is the section of the mandible that I've removed. And you can see it's a little bit over the 12 millimeter mark that I needed, somewhere around 15 millimeters approximately. But you can see it does taper back more towards the posterior. So pretty good. And I used a surgical burr to remove that. Then I come with my osteotomies. I placed 1, 2, 3, 4 osteotomies in the mandibular anterior area. I got real thin on this facial aspect. So then I move the position a little bit further back, staying away from the middle nerve as you see here. Then it's just a matter of freehanding, placing my implants one after the other, all torquing out into these areas as best as possible. These are 3.8 by 15. These are 3.8 by 12s. And these have, once these are torqued out, now I'm ready to place my implants in the posterior area, going back and forth between my CT scan and this here, the actual patient. So I'm pretty happy here. At this point in 2010, I have a little fracture, you can see, and I don't quite yet have this implant submerged. So I'm going to go ahead and bone graft this area and suture. And I think probably the most important thing I like to point out of this image, and I presented this in Washington, D.C. the following year in 2011 at the AEID conference, is I kept these abutments on and I loosely sutured with Gore-Tex sutures, allowing, and these are 3.8 millimeters, approximately 4 millimeter implants. And these are approximately 4 millimeter abutments. I left the tissue out on all of these areas and allowed for secondarily granulation to occur. And just keep this in mind, and also keep the first image in mind of the preoperative before we laid our surgical flap of the soft tissue. So now what I did was I took a CT scan post-operatively just to check all my implant sites to make sure I am within the bony housing. And as you can see here, it's pretty evident that the mandible was reduced enough, and my implants in each area were placed within very good sound vital bone, freehand, and at this point, I'm very pleased. Looking at other images, you can see I am 5 millimeters away from the anterior loop, 2 millimeters away from the middle nerve on the posterior implant. Same thing on the opposite side, 6.9 and 2.68. So now she has to heal. I'm going to leave her just like this, and I'm going to let this area heal. I'm going to keep her. This is going to be non-loaded area. She's not wearing her loaded denture right now, and or previously to the surgery because she can't chew. So it's just going to take a little bit longer for this area to heal. And in 2010, I just said, don't smoke, keep a soft diet. I'm more concerned about my soft tissue in these areas. I just informed her about possible swelling, and I put her on some medications to control pain, and no antibiotics. So in 12 weeks, I had her come back in, and I took a photo. And this is the soft tissue at this point. I'm fairly happy with all these areas. You can see I have a broader band of connective tissue attachment around these areas, except for this one implant where the soft tissue did not grow over. And I'm going to take another panoramic image to make sure the implants have integrated. It looks like they all have. So at 12 weeks, the soft tissue is still not sufficient. Number 30 site is showing through. At this point, I need to uncover all my implants, check if any of it have failed. And then what I'm going to do is just uncover these with just making a horizontal incision across the soft tissue in these areas and placing a 4 millimeter healing above it. Then it's on to the restorative process. Now that the soft tissue is healed, I'm going to go ahead and start to restore. I'm going to take an open tray impression, and I'm going to pour it up in my lab, and then I'm going to start the prosthetic reconstruction with my laboratory. So I get her back in to start to deliver the prosthesis at 16 weeks, and I'd like to present the soft tissue at this point. This is the soft tissue healing around my implants. And this was the part of the presentation in Washington, D.C. at the AID meeting that I won a prize on for soft tissue adaptation around implants non-surgically. And basically the point was allowing, based off principles of biology and soft tissue, to allow for secondary granulation and thicken the biotype and the soft tissue in these areas without using palatal tissue or without using alloderm. For the prosthetic reconstruction, she wants fixed. So I'm going to make her a fixed hybrid lower denture that's going to get screw retained. That's what this is. I went straight with non-engaged abutments straight into the mandible, into my implants. That's the prosthetics. I actually waxed up the bar myself. I just bought some non-engaged abutments, waxed it up with some dental lab, had it casted in cobalt chromium, and had my lab place the denture teeth in the acrylic for me. This gets screwed down to the patient's mouth. Triad pink in the anterior, and in the posterior, we just use composite. And this is the first time the patient has chewed in a class 1 occlusion in 58 years. She was very pleased. She got out of the chair, started chewing a piece of gum. I was very pleased myself. And then she went on later to get the upper denture replaced. She was very happy. So 5 years post-operatively, this is what she looks like. Implants have still integrated. She's still happy. She's still doing well. And I just want to bring a point up of what the soft tissue will look like before and after. This is probably one of the biggest points that I like to make in presenting this case is the thickness of the biotype. Mind you, this is a 4 millimeter implant, so I have 1 to 2 millimeter, 2 millimeters of tissue here, 2 millimeters of tissue here. So let's see, 2, 4, 8 millimeters of soft tissue from this. So this is all about complications and how to avoid complications. And what I'm doing now is completely different from what I was doing in 2010 on that full arch case. So this is our patient in 2016, and I started working with a very well-known dentist in Blue Sky Bio, Dr. Corey Glenn. And this patient was missing some posterior teeth. He does not have a lot of soft tissue in the posterior, and he has very thin bone, as you can see here on this panoramic. Pretty much the same thing as the patient before, except this guy has natural teeth in the anterior. He has posterior ridge deficiency and an uneven plane of occlusion. You can better see that on better images, such as these CT images. So the canine in 22 site was completely hopeless, along with tooth number 21. The canine in tooth number 27 site had horizontal and vertical bone loss. So then there was a matter of fact of just removing the mandibular 4 anterior teeth that also had some periodontal disease. And it was a questionable long-term prognosis, and the patient wanted fixed. So we discussed removing the remainder of his natural teeth, and very similar to our last case, place 4 implants in the mandibular anterior area and 2 implants in the posterior area. What's different about this case from the last case is everything was done in Blue Sky Bio Plan. And the workup was, if you're familiar with the software, we're finding our nerves, adding our implants into the software, where they are going to be prosthetically driven reconstruction. And then I use what's called a segmentation of the bone, advanced jaw segmentation. And I turn this DICOM data into an STL. So basically I turn an image file of DICOM data into an actual model or an object that can be 3D printed, like this pink jaw down here. And then once you have it as an STL or an object, then you're able to manipulate the jaw, make surgical guides, or make bone reduction guides that we'll do here in a second. So this was actually worked along with Dr. Corey Glenn in 2016. And what Corey did was, this was one of the first cases that him and I worked together with. He highlighted all of the teeth in a software called Mesh Mixer that's free. He digitally extracted the teeth and then what's called plane cut in Mesh Mixer. Now the implants, as you saw earlier, were already worked up in Blue Sky Bio Plan, and these files, this STL file that was segmented, was exported out of Blue Sky Bio so they could be imported into Mesh Mixer. Then once in Mesh Mixer, he extracted the teeth, then was able to use a plane cut tool to then figure out how much bone we need to remove till we get down to a correct horizontal plane of occlusion, all done digitally. So this is another image of the bone reduction guide, how much bone we need to reduce in the mandibular anterior area, our 4 implants coming out from the lingual aspect of the mandible, and our 2 posterior implants here. And this is just another image of highlighting the implants and their positioning, and then the bone after the section of what it's going to look like. And then from there, we're able to import the bone cut or the segmented mandible that's reduced back in Blue Sky Bio Plan software, and then we're able to digitally design a surgical guide. In this case, I designed a pilot drill guide, and then I was able to export the mandible preoperatively, the mandible that was segmented and cut, the pilot drill guide, and the bone reduction guide. So as you can see here, the pilot drill guide, I printed on a Cell Robox printer. It took about 3 hours and 13 minutes, and I printed for 41 cents. And I also printed out the bone reduction guide and the mandible that's reduced. And if you print out all of the guides together, it would take 17 hours and 36 minutes, along with the two mandibles, and it would cost me $3.10. I print all of my guides on a Cell Robox currently, and I use a support, a brim of 2, and a fill density of 40%. I've heard a lot of other people using fill density of 90%. I'm fine with either. That's just what I've been doing. So now that we have all this information, we have the angulation of our implants, we have the depth of our implants based on the bone reduction guide and the surgical guides worked up in Blue Sky Bio Plan. We have everything worked up from a prosthetic standpoint on how much bone we have to reduce to get 17 millimeters of clearance for a final prosthesis that's going to be fixed. We have our guides printed and our mandibles and everything's checked. So now for the day of the surgery. So this patient is going to get a full thickness flap reflection, very similar to the first case that I showed you guys. And you can start to see the bone or loss around this area, the hopeless prognosis of this tooth, hopeless prognosis of this tooth. And you can start to better appreciate the deficiency in the posterior mandible in both of these areas, with very poor quality of bone. Had this canine been a little bit better in the periodontal condition of all these teeth, and the long-term prognosis has been a lot better. Obviously we've done some things to try to keep these teeth, but it was obvious and discussing after the patient that we were to remove all these teeth. So after you reflect, we wanted to appreciate the mental nerve on both sides, as you can see here. And then we need to get enough flap reflection on the buccal and on the lingual from the retromolar pad through the retromolar pad respectively, to be able to fit our bone reduction guide. So this is the picture of the bone reduction guide. This material I no longer print with. I'm now printing with Gen Clear, and that's lowercase n, capital G, lowercase en, and it's made by Color Fab. So to get this to seat properly and to seat all the way, it's a little difficult. This is 3 millimeters of thickness, and that's a default on Blue Sky Bio Plan. You have to pull the tissue to surround the surgical guide on the buccal and the lingual, and do the same thing on both sides before you're able to push down on this guide to hear an audible click on the mandible for this guide to actually lock into place. Once completely seated, and you have to make sure that all the soft tissue is out of the way on both sides, buccal and lingually, then you're able to go ahead and reduce the mandible. Now, this can be done in two different ways. One way is to remove your teeth and then reduce the bone. The second way is to remove the teeth and bone in one segment. I chose to remove the teeth and bone in one segment. I've done some things to modify my technique. I'll show you a very brief, it's a very long video, but I'll show you a brief synopsis of the video. In this video, I'm using a Lindemann burr, Lindemann surgical burr on a surgical handpiece with copious irrigation. And initially, what I'm doing is making sure that the guide stays in place, and I'm slowly removing the buccal portion of bone before I start to feel the teeth. And then I'm edging my way through the buccal of the tooth, then through the midsection of the tooth, and then transversing back and forth, not trying to heat up the bone at all. And moving back and forth and back and forth. I'm going to speed this video up a little bit. This does take some time. So what I'll tell you is what I've done now is, instead of using a surgical high piece handpiece, I'm now using a surgical electric handpiece that has much more torque, and it's a little bit faster and easier to remove. So once the teeth are removed, I can better appreciate how much bone I have to reduce for this case. Since this was my first one done 2 years ago, I wanted to make sure that, and I don't know if you guys saw that or not, but it was pretty evident that the guide snapped out of the patient's mouth. Now I'm just taking a KS9 burr and flatten out the ridge. There's other surgical acrylic burrs that we use on straight piece now. That's just a closer view of this. I'm going to kind of get out of this and continue on with the lecture. So essentially what we did was reduce the bone and the teeth all in one piece. I get questions over and over on why I did it this way. In the treatment plan for this case, I used the dimensions of the teeth and the proximity of the teeth to place my implants in the guide digitally. So my thought process was, if I keep the teeth and the roots in after, if I remove the teeth all in once, then I pretty much lose my orientation of where I need to put everything. But if I'm able to make my bone reduction guide and reduce the teeth and the bone all in one segment, and after I remove my guide, I will know if I've fully, if the guide was just as accurate as I did it on the digital model. And actually it was almost, I didn't see any issues. So, and then I was able to just take a quick photo of the bone and the teeth that were moved in one piece. A couple different images of these. And again, I guess you can appreciate the vertical bone that was removed with the surgical burr. So after the segment of bone and teeth are removed, then we're going to go ahead and place our pilot drill guide on top of the bone. After the little root tips are removed, they're very easy to remove at this point. You just take an elevator and pop them out, and they just kind of pop out one by one. And then we put our bone guide for pilot drill osteotomies on the patient's mandible. Drill our pilot drill guide, widen our osteotomy, and then eventually place our 4 implants in the mandibular anterior area and our 2 implants in the posterior area. Again, very similar to what we did in the previous case. Next, what I typically do is graft on top of this with some bone and place some PRF on top, and then suture everything closed. This case was not done immediate loaded. There are different protocols for immediate load versus not immediate load. That is to be discussed at a later time, and whether I immediate load or versus not immediate loading. This was the day after he came back for healing. This is what it looks like. Again, this was 11/3/2016. Everything seems to be healing very well. This is a 6-day post-op healing. Little to no pain, little to no discomfort. This is 16 days. The soft tissue is actually looking pretty good. This is 3 months of healing. Patient is ready to be exposed. Again, pretty much the same 15C blade, sound to bone, incision across the crest, retromolar pad around this area to expose our implants. You can see with the day of exposure, we have good, healthy, sound bone over our implants. and nice heme state, nice bleeding. This is very good vital bone. We did not burn the bone. We don't have any bone dieback from any liniment burr, any of that bone reduction. So now all we do is my main focus now is to thicken the soft tissue. And this was just a proof of concept. This has been further developed to what I'm doing now. And what I did essentially was ask the patient if he wouldn't mind going without teeth for a few days. He said that would be fine. I placed on healing abutments and allowed the patient to heal, and then had him come back in a few days. What I did was I took these healing abutments in, took this photo. I then removed them, placed on some zest attachments to try to get his lower denture to somewhat lock in as a zest retraining lower denture. I did have some issues I want to point out on my posterior implants. The implant system I was using for this case, I no longer use. The company had changed the design of these implants because they had a very low success rate. So I had to remove both of these posterior implants, replace this one implant. We were not able to replace this implant in the 19 area. And this is removing the back implant and replacing the implant in the posterior area. This is after it was removed. So what we do now is look at the band of soft tissue attachment. I don't know if you guys can remember. I don't know if I could go back real quick to briefly show what the soft tissue looks like after 3 months healing. Then leaving the tissue or the bone exposed, leaving the tissue without suturing, and getting soft tissue to look like this. Again, this is a 4mm implant. This is approximately 2 millimeters, 3 millimeters. It's approximately 2 to 3 millimeters. This is very nice, thick, soft tissue around this area. I'm much happier with this than I would be taking a tissue punch to the little bit of keratinized tissue that I had. At this point, I'm going to take my final impressions, mount this up in my lab on an articulator and a face bow, and then start the digital design process using 3Shape software. And this is all done virtually and approved over email with my labs. Right now, what I'm doing is I'm milling custom titanium abutments on all these areas for full arch cases, like you see here. And then what I go straight into a provisional milled PMMA. In this milled PMMA, I'm double checking the patient's occlusion. I'm double checking the aesthetics. I'm making sure he's happy. He's going to sit with this for approximately a month to 2 months, making sure he's completely happy. He comes back in. If there's no adjustments made, this gets final milled at our lab and then delivered. And I keep the PMA just in case any issues arise. If there are adjustments that are made, then I can digitally scan this PMMA or even duplicate the PMMA in my lab and then send that back to the lab, and they can digitally scan it and then make the adjustments in the software before they finally mill a full arch zirconia. So,
can I jump in here with some questions?
Please, help yourself.
Okay. Submitted by viewers. How do you maintain tissue stability without sutures?
It's a very good question. There are different techniques that I review and go over. One is a horizontal mattress. So what you would do is enter the soft tissue approximately here, grab the soft tissue here, and then go all the way towards the back, and then suture here to at least keep the soft tissue on the buccal and lingual close to the bone, and then leaving the soft tissue essentially open around here, either placing PRF or not placing PRF. I'm showing both cases on not using anything and using PRF, and I like to show the results of those. That's there's not enough time in this lecture for a 1 hour presentation. And you can also do the same thing on this side. That's one way of getting the soft tissue to approximate. I hope that answers your question.
Okay. Did I understand correctly that there are no antibiotics?
So the first case that I showed you guys, there was not antibiotics. The second case where the guy had periodontal disease, yes, I did give him antibiotics just in case.
Okay.
There was no active infection in the bone, but I still did it just in case.
How do you treat the dental papilla? Do you cut only the vestibular or also the lingual?
I'm guessing you're meaning this case because we only have papilla in this case. I do not remove papilla. Some people would just remove in papilla. I'm fine with that if you want to do that, but I try to keep as much soft tissue as possible. So I make an incision in between each tooth, incising the papilla through, reflecting back, and you can see that in some of the images where the papilla we're trying. I'll go back on those images. You can kind of see here little papillaries where the papilla were. I like to try to keep those. It just gives me a little bit. If I cut that, you can see I'm going to lose a little bit of soft tissue right there. A little bit of soft tissue. And you can kind of see them here and here and here. Any other questions?
Nope. That's it for now.
Okay. So back to our slide. So at this point, the patient is happy with the aesthetics of the PMMA. This goes to get milled, and we're going to finish the case. Again, we had a bone implant loss right here. So we just did a 2 cantilever bridge on 5 implants. He's now been in function for 1.5 years and very happy with this case. So what I'd like to point out again is the soft tissue on the before and after. This soft tissue is not too bad. This soft tissue is not great. But then comparing this soft tissue to the actual day of delivery of our custom abutments, I think the soft tissue looks just absolutely stunning. I'm very, very pleased with the soft tissue. And again, there are many techniques to be able to get soft tissue like this without using products that you purchase. So at this point, again, in 2016, I was very pleased, but I want to make sure that the accuracy of my surgical guide, even just using a pilot drill guide and my bone guide, were just as accurate as I worked up with Corey Glenn in the software. So I took a post-op CT scan, and I imported those back into Blue Sky Buyer Plan as a scan appliance. So this was the treatment plan. And then this image here is the overlay of the treatment plan versus the actual implants. And you can see this is the planned implant here, and the overlay of the implants are exactly in tune with the implants that I planned. Clicking on each one individually, you can see how accurate this was. I was extremely ecstatic to see the results of this before and after. This was the planned, and I was stunned to see how good this came out. So the relevance of this doing it guided versus not guided would be going back to 2010 when I did this case, non-guided and now guided. And there is an obvious appearance in the views and the CT images of it, doing everything freehand, looking at a CT scan image and measuring versus using a surgical guide, bone guide, the day of surgery. And I want to point this out because the day of the surgery for this case, I didn't want to remove too much bone, but I was more focused on removing enough bone. so that I could get her into a class 1 occlusion. This is a much more accurate approach using surgical guides and 3D printing on a Robox $1,500 printer, and anything that I could have done for this patient. I was extremely pleased. So looking back after this case, I started to look back at my old cases that I had completed previously, doing full arch reconstructions on patients. And you can see the implants are integrated. This is a full arch upper and lower zirconia full arch fixed case. They have extractions. The implants were placed. Impacted wisdom teeth were removed from sinuses. And, the restorative outcome is good. Patients are very happy with the before and afters. I'm very happy with the before and afters. Here's another case that I did freehand, just by looking on a CT scan, extracting teeth and placing implants the day of the surgery. And, in the patient's opinion, this is an extreme makeover. She was extremely ecstatic with the before and after result. And I'm very pleased that she's happy and now able to function. Another patient here, before and after, you can see a hopeless dentition on the top and bottom. Removed all the teeth, placed 6 implants on the top, placed 6 implants on the bottom, and full arch upper and lower reconstruction. The before and after results, I think everybody could agree, are decent. And I think a patient could be happy with this. And final case, another patient, full upper, full lower, periodontally involved teeth, hopeless dentition, very affluent individual, was in a business meeting, and he was going over a multi-million-dollar project whenever his mandibular anterior tooth fell out of his mouth and landed on the table right before they shook hands on the deal. So he came to see me right after, where we placed 8 implants on the top, 8 implants on the bottom. He was an engineer and wanted to over-engineer the upper and lower. And I think everybody would agree that the before and after is improved. So, but all those are non-guided. All those cases are non-guided, and all those cases were in before 2016. So what am I doing different now, and what has changed my practice dramatically since 2016, and has helped me avoid complications and helped me improve implant dentistry in my practice and provided a better success for my patients, is changing everything that I've done to full mouth reconstruction, going completely guided, using bone reduction guides, surgical drill guides on partially edentulous, fully edentulous, and even single teeth implants. Now, this is in most of these cases, or all these cases I'm going to show, are full arch reconstructions. There's an obvious need for single tooth, more so in my practice and a majority of practices. This is a before and after result of a patient that hadn't seen the dentist in over 35 years. This is a before and after CT scan, and the prosthetic reconstruction is, to me, just as remarkable, if not more remarkable, than the surgical outcome. Going forward, showing more cases of full arch treatment, and what I'm doing continually, and you can see this is moving more towards full arch guided, immediate loaded cases that I've done, worked up in Blue Sky Bio. And it's, in this case, you have a full set of teeth, and there's different ways to remove the teeth, either sequentially before you place your implants, or removing the teeth completely before you place your implants. And this case is unique in that in Blue Sky Bio software, this was the first time I had the opportunity to segment both the teeth out and the mandible and the maxilla separately. I did not do the segmentation. I think segmentating the mandible is very predictable and very easy to do. The maxilla is very difficult, but the time it would take to segment the teeth and the bone is astronomical, and I don't recommend it. So I send this out to a third party company that does all the segmentation for me. And really, the neat part about this is um, the point, or what I wanted to do is, instead of serial extraction, the teeth, to place a guide on the teeth that were periodontal involved and loose, I didn't think they were sound enough to place a surgical guide on and get off. So what I did was had the company segment the teeth off from the bone. As you can see here, I lined up and placed my implants, and I was able to digitally extract the segmented teeth, almost similar to what Corey did for us in the last case. But this case, I was able to take a cone beam data and then actually digitally image and make a digital denture that's being widely discussed now, and make sure that lined up prosthetically with the final outcome for the immediate load situation, and then also make a surgical guide for the denture and for the mandible. So taking a patient that has advanced periodontal disease and going from something like this, day of surgery, we extract all the top teeth, remove all the bottom teeth, place our bone guide on the mandible, place and torque out all of our implants, immediate load with multi-unit abutments, take our titanium cylinder temporary abutments, torque those in, convert our 3D printed denture onto our 4 implants, immediate load the lower. The maxillary bone was insufficient. All implants did torque out, but the bone was very soft. So we elected to not immediately load the upper, but and the final reconstruction for the upper is going to be implant supported overdenture. I don't, if she was going fixed, I think we'd have thought a little bit harder about immediate loading the upper. The lower, she is going fixed, and so what I want to drive home is, I've pointed out in the first 2 cases that soft tissue is probably one of the most important things that I stress nowadays in full arch cases, because I see it's an underutilized therapy, and overlooked therapy across all presentations that I'm seeing now. And it's difficult. It's a very difficult process to be able to get thick tissue on a case that has full arch reconstruction, extracting teeth and placing implants at the same time. So to take a patient to go from here that has obviously bad periodontal disease, lots of bugs, soft tissue will retract in these areas. I will have some soft tissue issues, and immediate load. So this is my new protocol. Immediate load our implants, and be able to obtain a predictable 6 to 9 millimeters of soft tissue around our multi-unit abutments on an immediate loaded full arch fixed case, and have a predictable restorative outcome that is prosthetically, surgically generated, and has a very high long-term success rate, using the multi-unit abutments that I purchased. I actually purchased these from Blue Sky Bio, and use their implants. And then taking our open tray impression with our multi-unit abutment analogs, using floss to thread, either using Prima pattern resin that's light cured, or GC pattern resin. But we know that Prima pattern has a less than 5% shrinkage rate. GC pattern has a higher shrinkage rate. So after we cure these together, we will section each one and then recure these individually. And then this goes off to the lab. Again, the same process to design everything 3D and get a beautiful final restorative outcome that looks something like this, that is screw retained. I'm very big on screwmentation. Also, I just presented this case today in a another Facebook group called Implants in Black and White. This patient with a lower remaining hopeless dentition, we're able to remove all of the lower teeth utilize these 2 implants here. Just place 4 implants, reduce the bone, and get a very beautiful custom abutments. This is a temporary bridge that I had milled from Burbank Dental Lab. I'm actually not doing the restorative for this patient. He's actually going back to his referral dentist to get the final crowns. He will sit in this for 4 to 8 weeks. And then at the final prosthetic reconstruction, we're going to obviously make some screw access holes because all these abutments you can see, all the access holes are coming out through the lingual. So this final case will be screwmentated down. So the zirconia will be milled with screw access holes across, cemented with permanent cement, so that this is retrievable. I think it's very important for final prosthesis. And I think it's very important to keep patients in a PMMA temporary for at least 4 to 6 weeks to double check and make sure that they're happy chewing, parafunctional habits, etc., are all worked out before you go into the zirconia. I highly recommend whenever you do zirconia that patients sleep with a night guard at night to protect the zirconia. This patient will be easily restored by the restorative dentist because I don't think we're going to make any adjustments, or not many adjustments. And that pretty much sums up the lecture for what I've done in the past couple of years to change my practice by utilizing Blue Sky BioPlan software. Going forward, if you guys want more information, I'd recommend going to download. There's many podcasts out there. I'm a big fan of podcasts. You can download AID podcast. I co-podcast with Dr. Justin Moody. It's a very good podcast, and I'm a big supporter of the American Academy of Implant Dentistry. You can also visit Facebook private group Implants in Black and White to learn more about what my partner and I are doing. And then there's the course that we offer twice a year. And it's blackwhiteimplants.weebly.com is a URL. You can watch the video, and April course of this year is actually sold out. Registration's open for November course. And if you go to registration tab on this website, you can now sign up. This is live today for the Advanced Full Arch course in Winchester, Tennessee. I'll be teaching with Dr. Corey Glenn. We'll be going through the software and Blue Sky BioPlan, showing cases of before and afters, and showing how I get soft tissue, using multi-unit abutments, immediate loading, full arch fixed cases, and getting the results that I'm very pleased with and pleased to show. And I say this Dr. Smith and Dr. Domingue, Dr. Jerome Smith is my uncle. That's who I practice with. The course that we teach, all proceeds that we make actually are donated to a medical mission trip that we go on twice a year, and we take the LSU School of Dentistry students, and it's whatever proceeds we make go towards this. So I don't have a problem plugging it because it's all for a good cause. So I want to thank everybody for listening to the lecture. It's time for me to get back home to my wife and my daughter, who I'd like to spend some time with. If there's any other questions I can answer.
Yeah, there's some questions if you have a few minutes.
Sure.
Okay. Do you prefer, for dual arch fixed cases, do you prefer zirconia over zirconia prosthesis?
That's a great question, and it's not a simple answer of yes, I do every single time. It typically depends on the patient, the age of the patient, the weight of the patient, the sex of the patient, parafunctional habits of the patient. I was really big into zirconia whenever it first came out because I saw the advantages of it. I joined a practice that had been around for 36 years, and it was predominantly implant based. And the best restorative option at that time was PFM. And the complications that I was seeing with PFM were obviously porcelain chipping, and the repair of the porcelain chip is very difficult. I still think PFM is a great restorative material to use in the right instances for full arches. I don't think it is out of the question. Zirconia, when it came out, was, and the ability to be able to do cross arch stabilization with zirconia was just incredible. To have 1,000 millipascals of strength of zirconia is outstanding. However, there is a lot of literature now being produced, and what I've read, and I've actually seen in my own practice, where we do see some full arch cases of zirconia fracturing, and obviously it fractures around the weakest point, which is around the implant. So initially, I was doing a lot of implant custom abutments with cementable crowns or cementable full arch bridges, and I've tried various different techniques to either do zirconia over zirconia, zirconia over this. There's another material, I can't think of the name right now. I can't think of the name off the top of my head. And then acrylic over this material, which is fantastic. This is a subcobalt chromium milled framework with hand stacked. You can either do porcelain, or this is a composite. I cannot remember the name of the composite. It blows me away. But I got this actually back from the lab, and it did not have ovate ponics, so it was just very easily to go in my lab and add some bond and add some composite in my lab for this patient, and then polish it, and then add pink composite and polish it. So the repairability of this material is exceptional over zirconia. So it's not I do like zirconia of zirconia. It's probably one of my go-tos, I would say, initially thinking about cases. But it's not, I don't think it's the right choice for every single case all the time. I hope that answers your question. Thank you for asking.
Okay. You talked about screw minting, that you're in favor of screw minting. Somebody asked exactly what you mean by that.
Screwmentation, you can actually Google it, but essentially it's called screwmentation. So essentially you have screw attained custom abutments that are screwed into your implants, and your final crown and bridge work has screw access holes in it. So I cement those with permanent cement. So what I do is I'll torque in my custom abutments. I'll seal off the abutments with Teflon and flowable composite. I'll fill the area with Fuji cement that is radio opaque. I'll fully cement it on all my abutments at the same time, and the excess cement comes out through all those screw access holes. Then I seal off those access holes with composite if it's deficient, and that's how the patient leaves. If there's any issues with the prosthesis or an implant, it's still retrievable because I still have my screw access holes out of the occlusal surfaces of the molars or the lingual surfaces of the mandibular anterior area or the maxillary anterior area. If there's an issue with the angulation of the mandibular anterior, custom abutments where the screw access hole is coming out the facial, those custom abutments will get cemented with a temporary radio opaque cement, and the posterior implants will get cemented with a permanent cement, so that the final prosthesis, again, is still retrievable just in case there are any issues. If you have ever tried to cut off a full arch zirconia implants bridge that is permanently cemented to custom titanium abutments, believe me when I tell you, it's a long appointment, very arduous appointment, very difficult for the patient, and you will spend lots of time and lots of money on burrs to get through that. So on full arch zirconia, I highly recommend figuring out a way to make it prosthetically removable, if at all possible.
Okay, a couple of technical things just to wrap up. Everybody should complete the webinar attendance form. The link is in the chat box next to the video box. This way we could send you the CE credit. And along with the credit, we send a questionnaire. We appreciate it if you take a minute just to fill out the questionnaire so we could improve the webinar experience for future presentations. The future webinar schedule is listed on the blueskyplan.com website /webinars 2018. We have the presentations that are coming up listed there, and recorded presentations, including this one, is available on YouTube and on our website. If you search YouTube for Blue Sky Bio, then you'll find them there as well. Danny, there are a tremendous amount of comments with positive feedback. Thank you for taking the time for the presentation and presenting this information. Very informative and very useful. And I'd also like to thank you on behalf of Blue Sky Bio for taking the time and giving over this presentation as well.
Thank you, Mike. I appreciate that.
And I'd like to thank everybody who took the time to attend the presentation, and we look forward to seeing you at future presentations. Have a good evening.
Thank you.